Okay, kia ora katoa. Welcome to the New Zealand Cerebral Palsy session. Te rehita a hoka i nukarangi Aotearoa. Tēnā tātou katoa, no tāmaki makaurau au, e kairanga hau au I te whatuora te tokatu mai, ko Anamaki taku ingoa. Tēnā tātou katoa. So welcome everybody to the New Zealand Cerebral Palsy Register session. Thank you for being here. My name is Anna Mackie and I'm working with the CP Register and we're here based in Auckland. So just housekeepings, please remain on mute throughout the session and we will have questions at the end where we will open up. If you've got any questions during the session, please put them in the chat box and also do take the opportunity to share where you're joining us today from in chat and what your interests are to help make connections. So before we start, we're going to lead with a karakia. Whakatakata ki te uru, whakatakata hau ki te tonga, kia mā kina ki uta, kia mā taratara ki tai. E hi aki ana te atakura, he huka he tio ki hauhu. Turu o whiti whakamoa kia tina, hau miei, hui tai ki e. Okay, and with that, I'm going to hand over now to Professor Sue Stott, who is the chair of the New Zealand Cerebral Palsy Registry, who will introduce the talk and the team for today. Thank you.
Thank you very much, Anna. As she says, I'm Sue Stott. I'm the chair of the Cerebral Palsy Register and also paediatric orthopedic surgeon at Starship. I think first off, I'd like to acknowledge the funding from the Starship Foundation. It was their funding which helped us to get the register going in 2015, 2016, and they've been great supporters of us since that time. I'd also like to introduce the team, Alexandra Suhaga, who is a research officer with the register, Anna Mackie, who is project manager, working on the project managing the relationship between the Cerebral Palsy Society and the register, and Warud, who's come on board as research officer. So next slide. So why have a register? Well, we don't know how many people in New Zealand have cerebral palsy and how it affects their lives. So a register can really use combined information about all people with cerebral palsy in Aotearoa, New Zealand, to understand what living with cerebral palsy means for different groups, such as Maori, adults, or people living in different parts of the country. It also helps us guide health planning, and our goal is really that all people can access the right health services at the right time. And a register is potentially one way to monitor those outcomes. It can also provide information for groups who wish to advocate for different services, such as the Cerebral Palsy Society of New Zealand, and it can also help promote new and innovative research about cerebral palsy. So this is our first look at our data, which we've collected over the last 5 to 6 years. So about 1,400 individuals with cerebral palsy on the register living in New Zealand. About 3/4 of them are in the paediatric age range. 14% were born overseas, but overall our population distribution is quite similar to the population as a whole, with 45% New Zealand European and 26% New Zealand Maori. Of note, 43% of individuals on the register come from Tamaki Makaurau and 44% come from Te Aka Maui, and a relatively smaller proportion from Te Waipounamu, the South Island. Next one, yeah. So like other registers, the majority of individuals have acquired cerebral palsy either in the pre or perinatal period, and about half have been born preterm. Walking is the main form of mobility, with 70% being GMFCS levels 1 to 3, but many of our individuals with cerebral palsy also have associated conditions. The timing of our first cerebral palsy description in the notes is really a little bit behind where we see the Australian data. About 40% receive a CP diagnosis by 12 months, and 17 months is the median age at which we first see the cerebral palsy diagnosis appear in the medical record. But that is delayed compared to both Australia and internationally. Unlike Australia, we have 2 funding models, and about 13% of people with cerebral palsy on our register are under ACC. So let's go to the next slide. So in the last 5 to 6 years, we've engaged in a number of research activities. And this really has shown to us that there appear to be health and social inequities for Maori children with cerebral palsy. The first work was done by Georgia Witter, a medical student, did a summer studentship with us, looking at ethnic inequities in children with cerebral palsy within the Auckland area. And what she found is that Maori children with cerebral palsy have greater levels of disability when you look at the GMFCS classification, and they're also more likely to be living in a lower socioeconomic area. We've also done some work looking at hip surveillance, and we found that Maori children with cerebral palsy, when they have their first hip x-ray, are more likely to have a dislocated hip, which does suggest some delays, therefore, in obtaining that first hip x-ray. Similarly, children who are Maori are more likely to be admitted to Starship with secondary respiratory illness compared to non-Maori with cerebral palsy. So I think these findings were concerning to us, but what we wanted to do was really understand more about the Maori population and really understand, are we recruiting all children with Maori into the register, or are we simply getting a skewed group and therefore getting data which is hard to interpret? And so what we did was we reached out to Karen Wright, who's senior lecturer at University of Auckland and also a public health physician. And between us, we put together a research activation grant to the HRC, which was successful. And I'll get Karen now to talk about that grant and introduce herself. Thank you, Karen.
Tēnā koutou katoa. Thank you, Sue, for the kind introduction. Tēnei te mihi ki a koe e ana mō ngā karakia whakaritea o tēnei hui. So it was a privilege to partner with Te Rehita a Hōkai Nukurangi Aotearoa, the New Zealand CP register, to undertake this research. And you'll see the members of the register listed below. I also want to acknowledge the presence of Sian Williams on the research team, and also the three fabulous research assistants that we had, Rachel Tapira, Aria Daha, and Renata Kotua. So what did we do? Well, we really wanted to prepare the register for research that supports Māori health gain and equity. And so, as Sue has indicated, we focused on the comprehensive recruitment of Māori children and collecting high quality information. As Sue's already mentioned, that we were fortunate to receive funding from HRC, Health Research Council New Zealand, to undertake this research, for which we are grateful. So without spending too much time here, I really want to acknowledge that the foundation of this research was kaupapa Māori theory. So we're really seeking to transform systems and processes in order to address and eliminate unfair and unjust differences in health outcomes for Māori children. So here I'm really talking about inequities and shifting that focus onto systems and processes. Now, I'm only able to touch very lightly on what we did because I really want to get to the actions and where the register is now. But I'm going to talk through three key areas that our research was focused around. The first, and I think the fundamental action, was really whakawhanaungatanga. So this is about identifying and establishing or strengthening relationships. I'm going to talk through some of these relationships throughout this presentation, but at this point, just want to acknowledge district health boards, Te Whatu Ora now, in their role in increasing recruitment for those who have contact with hospitals and the tertiary sector. Now, a really important relationship to establish and nurture was whānau. And so this was really moving into our information gathering phase as well. But we were very fortunate to engage Health Literacy New Zealand and the wonderful Susan Reid to facilitate hui with whānau so that we could listen and learn. And so here you can see a couple of key learnings from these sessions. It became clear that our whānau engage with a health system that is complicated and not always supportive. The knowledge of the register was generally quite limited, and there were challenges to enrolment, not just from this limited knowledge and visibility, but also from the enrolment process itself. So what was spoken to us was that the register really needed to be authentic if it was going to commit to Māori health equity action. So we were provided with recommendations around three values. Whanaungatanga is about creating the space for good relationships, and this is a space that people want to engage in. So this is about making the purpose, the benefits, the value of the register really visible, and this includes the register team itself. Manaakitanga is about reciprocity. So here it's about developing mutually beneficial relationships with whānau Māori, with iwi, with other key organisations. And here we think about our NGO sector, including the Cerebral Palsy Society. It's important to ensure that information and progress is shared, but that this needs to be done in ways that meets the needs of different organisations and people, and particularly thinking of the needs of whānau here. Kaitiakitanga is about guardianship, and so this is ensuring that register data is being used to reduce these inequities for Māori and other populations, and part of this is making sure that the enrolment process is really clear and welcoming. So as I've already indicated, our second activity was around gathering evidence, and so we looked to the literature through a systematic narrative review. We identified 17 articles, and from these we looked to pull out barriers to ascertainment or recruitment of Indigenous peoples onto health registers, and we also looked for strategies for recruitment and high quality data. So again, just to introduce some of these key ideas. There were multiple barriers recognised to recruitment, and these occurred across the care pathway at individual, at health provider, health service and health system levels. There was clearly a perception that discrimination and access were significant issues and barriers to recruitment. We found that there was a bit of a disconnect though between the barriers and strategies. So although there was this breadth of barriers, the strategies really focused around individual responses and that access to service. So there was this big gap around what you can think of as the structural or foundational determinants of inequities, and that's institutional racism. Ethnicity data was an issue, the quality here. So it was often inconsistent, irrelevant, and of poor quality. And so this results in an undercount of Indigenous peoples in health registers. And finally, it was very clear that you need to involve Indigenous people in the identification of barriers and solutions and make a shift towards data sovereignty. Another area that we gathered information from was from health registers themselves, and we did this through environmental scanning methods of a survey direct to health registers and a scan of websites for organisations that didn't complete the survey. So here we were looking to international CP registers and in Aotearoa New Zealand health registers more broadly. So again, just to touch briefly on some of these key ideas, there was a lot of equality framing that became apparent. So this is where there's an understanding of giving equal treatment to all regardless of ethnicity. And often this is framed as I treat everyone the same. The concern here is that those really critical structural causes that I've talked about just earlier, like racism and power imbalance, they get left unaddressed and so persist in causing inequities. This flowed on to our second point around personal behaviour and access as explanation. So this was far more common and therefore those structural causes, as I've said, were left out. Ethnicity data quality was again an issue and was not seen really to align with what we recognise as gold standard here in Aotearoa, New Zealand. And finally, we did notice and observe that there was limited involvement of Indigenous peoples, and often this was relegated to advisory type roles rather than decision making. And so there was a lower level of power and self-determination for Indigenous peoples. So from this, we have pulled together a preliminary framework to centre Indigenous health equity in health registers. I won't go into the detail, but you can see indicated there our tukutuku panel. So this is the ornamental lattice work that's used between carvings in whare nui or Māori meeting houses. Some key things to notice there is that it includes Indigenous peoples' worldviews and involvement. There's also a place for non-Indigenous peoples here. The steps line there is called a potama pattern, and so that includes the key actions that we identified, noting that they are interconnected and ongoing, but there's also room for other actions. So importantly, health registers really can support Indigenous health equity, but they need to prioritise and take very clear equity action. And central to this is collaboration and meaningful partnerships, but particularly with Indigenous peoples. So just to finish, I want to indicate some of the actions that have taken place throughout and following on from this research. So I'm particularly excited about the structural transformation that is going on. And this is really looking like an operational and a governance restructure. And in a sense, it's doing it in a way to uphold Indigenous rights and to centre Te Tiriti o Waitangi more strongly in the register. So some actions this includes is a Māori data sovereignty audit and a plan, and we are very grateful to the input from Te Mana Raraunga and Te Kotahi Research Institute. Also need to acknowledge the contribution and support of the Starship Foundation in funding some of these actions. We also acknowledge and are grateful for the input from Health Literacy New Zealand in revising participant information sheets and also working towards producing other resources such as videos to increase the visibility and introduce and present information in more innovative ways. And we're really excited that the register will soon have a revised website with which to carry all of this wonderful resource and information. This research also led on to some work to identify a strength-based name for cerebral palsy. And so we're very grateful to Matua Kiri Opai and his wonderful work to produce this name, Hokai Nukurangi. So there will be a link provided in the chat to provide a bit more background into this process, but just to acknowledge that the name indicates the traversing of the earth and sky and the adaptation of individuals to the environment to achieve what is important to them. Now, finally, I want to acknowledge the relationship that was strengthened and has progressed with the Cerebral Palsy Society and has resulted in a memorandum of understanding, which has led to sustainable funding and development. And this opens up some incredible opportunities for research and innovation, particularly to develop a strategic plan to strengthen the voice of lived experience in the register. So a lot of wonderful opportunity for future research and certainly a future that has Māori health equity at the centre. So kia ora, I look forward to your questions and I'll hand back over to Alexandra.
Thank you, Karen. So kia ora koutou, my name is Alexandra and I've been with the Register since about 2015. So this indeed has been a journey, been amended to reflect our aims, our purpose and the actions we are taking to achieve these. And it will be available to download on our website in a couple of weeks' time. But just to give you a quick overview, the data we collect needs to be of high quality. And if you can move that on. And we feel this is a shared responsibility across health services and ourselves. For example, routinely using descriptors for CP, like the functional classification systems, for movement, for hand use, for vision, for communication. And then that will standardize the data we collect and make sure it's of high quality. So our recent research has also, and reporting has been really pediatric focused because of where we are, and it has been on that early diagnosis, but we are really, really keen to extend that across the lifespan of CP. And we need those with lived experience and their whānau to guide us on this path. And so leading on from this, high quality research is also important, and we feel it must reflect the priorities of CP in Aotearoa New Zealand. For example, we are wanting to work with the CP Society to establish a consumer group who can direct priorities of research in CP. And of course, we are going to use the data to identify inequities and understand priorities and monitor and advocate for Māori health equity. So what does our future look like? So looking at ways to make the register more sustainable. Sustainable is a very complex word, but this does include financial stability. We only have funding for about 30 hours a week, and we have really relied on research grants in the past to sustain the work that we do. But if we want to remain relevant and continue evolving, we need to be more sustainable in our funding model. We need to be sustainable in our relationships with our local health professionals, particularly those outside of the Auckland area, where it has been more challenging to get ascertainment for the register. But also moving to more of a prospective recruitment. So in other words, we have been quite busy inputting data for those that already have CP, but how do we make this conversation being part of the register and relaying the information to them that is meaningful to families at the time of that diagnosis, not necessarily on the day, but just at that time of being part of the register. And also really probably bigger thinking is really how do we move to being more of a quality register. So instead of collecting data at one point, which is what we do at the moment, how do we monitor outcomes? And a good example of that is the Children's Cancer Register, where they really look at treatments and is this effective, is this working? So being more of a living register. So the register doesn't belong to us. It belongs to our audience and those with lived experience, our whānau and our health professionals. And so we are looking at ways as to how we share with the data we collect in a way that is meaningful. And of course, keeping it all anonymous and ethically sound. We also want to improve our ability to use data to advocate by building relationships with key stakeholders more at the governmental and policy making level to be more efficient in our advocacy. And we also want to help us identify key research priorities and guide our activities through being part of our governance structure, which probably leads me really nicely into the next slide. So if we have inspired you to be part of our governance committee, we would really like to hear from you, and Anna and I will stay behind afterwards just to talk about what that might mean. We do have terms of reference available for you to see what the expectations are, but we probably want to talk about that if you're really keen after the session finishes, and we'll stay behind. And as I've said, a CP research group is not about being part of research, but actually having some oversight of research. What is important to people, the CP in Aotearoa New Zealand, and that can mean guiding that process or actually being fully immersed in research all the way to publishing papers. So, next screen, yes, this we want to promote the 6th of October, be green and be seen. So take out your green t-shirt, get it washed and ironed. That's not compulsory, but would be good. And wear your green shirt on the 6th of October and follow the link to the Give a Little page in the chat to make a donation. So this list is endless, sorry, and we probably have missed some people, but it would take up all of this presentation if we had to thank everybody, but particularly our health professionals who've supported us from day one, for all the funding we have had, for all the guidance we've had, and for all our research collaborators. Thank you. Tēnā koutou. Any questions, that's our email address. So I'll hand over to you, Anna.